welcome to the last session, the evening to night session as per Indian Standard Time. And it is my great honor and pleasure to introduce Dr. Darryl Adams. Dr. Darryl Adams is an associate professor of medicine, a medical intensivist, and an ECMO attending at New York Presbyterian Columbia Training in Medical Center, USA. He is the associate medical director and director of research at the medical ECMO program, as well as medical director of intermediate care and pre-critical care services. He has been actively involved in several committees, including the ECMO Net and the ELSO. Areas of clinical research and expertise include the role of ECLS, that is extracorporeal life support, in acute and chronic respiratory failure and pulmonary hypertension. And he's a proud winner of several teaching awards. So with that, I hand it over to you, Dr. Adams.
Thank you very much, Dipesh, and thank you, Ricardo and Laurent, for having me. Hopefully we have a little bit of time for questions at the end. So my task I was assigned today was to explain and try to justify the role of VV ECMO and ARDS, where it should fall. And so I phrased that as kind of rescue, salvage, or as standard of care, which I'll explain further in a minute. No disclosure. So, first of all, we have to ask the question, would we expect ECMO to save lives in severe ARDS? And there's a lot of proposed mechanisms for why ECMO may benefit patients with severe ARDS, a lot of it around gas exchange, but I would argue that the most relevant one, and that I think the data most strongly supports, is by minimizing ventilator-induced lung injury and minimizing the excess pressures and volumes that we may expose the lung to during mechanical ventilation. So if you believe, and if we justify in the coming slides, that ECMO does save lives in severe ARDS, what is the best role for it? Is it early ECMO, when you first identify the patient with very severe ARDS? Is it salvage, or is it rescue? And I'm going to define these a little bit better, because I think these terms get thrown around interchangeably when I think there are distinct differences between them. So in order so that we're all speaking on the same terms, salvage therapy, I want to define as something that you provide only after all standard treatment options have failed. Think of like salvage chemotherapy, where it's the last ditch effort. Whereas rescue therapy is a little different in my eyes, and that's when maybe either more conventional therapies are not available at the center that you're working, or are inappropriate for the situation. So this is, if you think of an algorithm for how you approach a patient with ARDS, maybe you're reaching for something out of sequence in the treatment algorithm because something that you normally go to first isn't available or not appropriate. So the data around ECMO, as I'm sure you all know by now, 8 years since it first came out, is the EOLIA trial. So ECMO for severe ARDS, published by Len Combs, senior authors Dan Brody and Len Mercat. And this was really a landmark trial of ECMO for ARDS, which really helped define the field. Now, the EOLIA trial compared what we call early ECMO, which is ECMO combined with an quote-unquote ultra-lung protective ventilation strategy, versus what they called in the paper rescue ECMO. But for our purposes, I'm actually going to redefine that as salvage ECMO, and I'll explain why. So early ECMO here is best practices ARDS management, and they're evaluated for the trial. They meet criteria to enter EOLIA, and they're on the ventilator for less than 7 days. Rescue, which again, really going to redefine as salvage, and it's important here to keep those terms consistent, is still best practices ARDS management, randomized to ongoing best ARDS practice management, and ECMO only if they are failing all of those therapies and effectively, maybe actively dying, with very strict criteria to cross over and receive ECMO. And this is an important point for the EOLIA trial that we should all take away. It was conducted in centers that can all do ECMO, because once they were randomized, they were quickly cannulated to ECMO, or they were within a network where you could get them to an ECMO center within a couple of hours. That means these were all centers that in some form believed that ECMO already works to some degree. Their equipoise for conducting this trial was perhaps a bit compromised because they have to be ECMO centers to begin with in order to conduct the trial. So in order for these centers to have the justification for enrolling patients, you pretty much have to offer, whether you believe it or not, you have to offer some crossover, because these ECMO centers likely would not enroll their patients if they thought there was never a chance for their patients to get ECMO, but at least there were very strict crossover criteria, which we'll define later. Okay, so what were the best practices ARDS management in leading up to enrollment and ongoing in the control arm? That's a lung protective ventilation strategy, a fluid conservative approach as appropriate with getting volume off, deep sedation, consideration of paralytics, neuromuscular blockers, and a high PEEP strategy if they felt it was appropriate. And importantly, prone positioning, which was conducted at a high rate in both groups. And if you remember, the PROCEVA trial came out in 2013, which is right in the middle of the enrollment of the EOLIA trial. So while prone positioning was not mandated at any point, it did become standard of care halfway through and was strongly encouraged. And ultimately, 90% of the control patients received prone positioning, and 60% of those enrolled in the ECMO arm, in the intervention arm who received ECMO, had been prone prior to ECMO cannulation. So very high rates of prone positioning. So the question then that EOLIA was trying to answer is early ECMO better than salvage ECMO, or control standard of care, conventional mechanical ventilation, other strategies with ECMO as a salvage option? They had to meet one of three criteria. At this point, you're probably all familiar with the entry criteria for EOLIA. That's a PDAF ratio of less than 50 for more than 3 hours, a PDAF ratio less than 80 for more than 6 hours, or the respiratory acidosis criteria of a pH less than 7.25 with a PCO2 greater than or equal to 60. So it was a respiratory acidosis, not just any acidemia, for at least 6 hours, with adjustments trying to get them out of that and keep the plateau pressure at 32 or less. Almost 250 patients were randomized evenly, 124 assigned to ECMO, of which almost all of them received ECMO, 125 were assigned to receive conventional mechanical ventilation. But as we mentioned, there was an option for crossover, and 28% of the control arm crossed over into ECMO, what we'd call salvage ECMO, on average about 6.5 days after randomization and enrollment in the EOLIA trial. But they were analyzed by intention to treat. So those patients were analyzed as if they had never received ECMO in the control arm. And here were our results. There was an 11% absolute risk reduction of ECMO over control, 35 versus 46%. Notably, those that crossed over had a higher rate of mortality, 57%. But again, analyzed by intention to treat as if they were control. But you have to consider the fact that if they had not received ECMO, how many of them would have died, and how high would that have control mortality have been if not for ECMO? And there's some secondary analyses to try and tease that out. But an 11% absolute risk reduction. However, EOLIA is considered by many to be a negative trial because by a traditional frequentist analysis, it did not meet statistical significance. The original powering of the EOLIA trial was to see a 20% absolute risk reduction from a control mortality of 60% down to a ECMO mortality of 40%. In reality, the control mortality was 46%. So in order to achieve that 20% absolute risk reduction, you would have had to see a 26% mortality in the ECMO arm, which is perhaps aspirational. All that being said, they still achieved an 11% absolute risk reduction, which certainly clinically sounds meaningful. So because it didn't meet statistical significance, it was not necessarily, some might interpret this as a negative trial, but what I would say is perhaps it's an indeterminate trial by a traditional frequentist statistical approach. There were other analyses they tried to perform to see what, especially with this crossover, which really muddled the answers. By intention to treat, you have on the left, that's the traditional frequentist approach. Again, 11% absolute risk reduction. 0.76 was the relative risk. The RPSFT is a model of trying to figure out what would have happened to patients had they not crossed over if they continued. And that nearly met statistical significance, but that's not exactly what happened to the patients. And then there's another way to look at it, which is treatment failure. Well, the treatment failure in the ECMO arm is death, but treatment failure in the control arm is death or crossover to ECMO. But that assumes that if you didn't cross over to ECMO, you were going to die. And it's not fair, I think, to say that they all would have died, but some would have if they didn't cross over. So the truth is somewhere in between the figure on the left and the figure on the right. So that primary outcome, again, failed to show the anticipated benefit of 20% absolute risk reduction, and therefore it was stopped early for futility to likely achieve that 20% reduction, not for clinical futility that it just didn't work. We have some other analyses after the fact, so to tease out because this was a very complicated, very interesting and sophisticated trial. I mean, we could speak for hours on this trial from a methodological standpoint, but they tried to analyze it after the fact. How do we interpret this in clinical practice? We all have our beliefs of what we think ECMO does, that it works or doesn't work. People strongly believe it works. People are more skeptical. We also have pre-existing data, such as the CSER trial, that provides us some information, but it is a methodologically flawed trial, and that it doesn't really tease out the impact of ECMO itself on outcomes, since it was kind of a pragmatic trial. Not everyone received ECMO who were randomized to the intervention arm. So a Bayesian analysis takes either your prior beliefs, your prior data, and incorporates the results of a trial to then, like a likelihood ratio, to then alter perhaps your posterior probabilities are of the benefit of a given intervention. So if we look at a Bayesian analysis of the EOLIA trial, there's lots of ways to look at it. You could look at it based on pre-existing data. You could look at it on pre-existing prior probability that you yourself believe that ECMO works or doesn't work. And basically, the most skeptical patients over here in the bottom right, even with the most skeptical, the yellow being the prior probability, calling up, a prior probability of neutral, that there's no difference between ECMO and control, it would shift your posterior probability would be that there's some benefit to ECMO. If you're strongly in favor or moderately enthusiastic that ECMO works, the data from EOLIA reinforces your prior beliefs in keeping that relative risk of mortality on the favorable side, given the fact that there was an 11% absolute risk reduction from ECMO over control. So across all prior assumptions, and even with the prior data that we have, the posterior probability of some mortality benefit from ECMO is quite high. That the relative risk is less than 1 is high. Nearly 100% chance that that's true. The difference is the magnitude of the benefit. Is it a 2% absolute risk reduction? Is it an 11% absolute risk reduction? Unlikely to be a 20% absolute risk reduction. And to take that into context, you have to consider not just what the intervention is for benefit, but what are the risks? What are the potential downsides of an intervention? And how do you weigh a 2% absolute risk reduction with perhaps a 40% risk of adverse events? Now, for what it's worth, the adverse events in the EOLIA trial, largely bleeding and thrombocytopenia, were relatively well tolerated. So the mortality benefit may be sufficient that you're willing to accept some of those adverse events if they seem tolerable and supportable. There are other ways to look at this with the existing data. There's systematic reviews and meta-analyses, because not only do we have EOLIA, we do have CSER, and we do have other observational studies. And if you look at a primary outcome of 60-day mortality based on CSER and EOLIA, it's strongly in favor, because CSER was a positive result, and EOLIA effectively, by where the relative risk reduction and the absolute risk reduction fell, were a positive result. So you pull those together, but with all the caveats of each individual trial, and there is a substantial mortality benefit from ECMO. But you have to know the data and the individual trials and their flaws. You can also look at this on a network meta-analysis level, where you can look at multiple interventions simultaneously and paired together, and what kind of benefit or harm those interventions have. And in that context, with 25 randomized controlled trials, not all ECMO, this is all just different RCTs for ARDS, 9 different interventions analyzed, 7,700 patients, but the overall 28-day mortality is 35%. And you could see that there's a substantial relative risk benefit of both prone positioning and veno-venous ECMO compared with just lung protective ventilation alone at 28 days. So this supports both either prone positioning and VV ECMO, but in combination, in this case, with a lung protective, low pressure ventilation strategy. Okay, so it appears, I hope I've convinced you, that at early ECMO, the EOLIA intervention at expert centers is with a strategy that is really important emphasis, not just putting cannulas in, but applying it with a ultra lung protective ventilation strategy, keeping the plateau pressures under 25, which tidal volumes are substantially below 4 to 6 cc's per kilogram. Respiratory rates well below the 30s in the control arm, down to between 10 and 30. FiO2s down, PEEPs of at least 10. That combination of early ECMO and better than the standard of care we can provide conventionally of lung protective ventilation improved outcomes in very severe ARDS. And this early ECMO strategy is better than that control strategy of conventional mechanical ventilation with an option for salvage ECMO. that waiting until that patient needs it as a last resort is not a good strategy with the highest associated mortality. So how does that then impact where we place ECMO in the algorithms for the management of ARDS? All right, so this is an algorithm that we devised several years ago. I think it still applies today with all of the subsequent knowledge we have. Up top, you treat ARDS with treating the underlying etiology, diuresis, perhaps resuscitation with fluids as appropriate, depending on the underlying etiology and the severity of shock. And then you can look at it between PDEF ratios of less than 150 or greater than equal to 150 because of all the trials that have used 150 as a dividing point. Strongly recommending prone positioning because that is where we have the strongest data for a benefit of a 50% relative risk reduction, a 16% absolute risk reduction in the PROCEVA trial. The other interventions of varying strength of recommendation, depending on the data you look at, neuromuscular blockade still seems to be very relevant and was fully employed on basically all patients prior to randomization in Eolia. PEEP strategy is still controversial, but probably higher PEEP is benefit. Pulmonary vasodilators show no mortality benefits, so that's something one can consider if they choose. Recruitment maneuvers are increasingly falling out of favor, and then we get to the point: are they getting down to Eolia criteria? So the one thing I want to emphasize one more time is that the consideration of ECMO should always be preceded by prone positioning, given the strength of the data in the PROCEVA trial and the fact that there were such high rates of prone positioning prior to enrollment in Eolia, unless there's an absolute contraindication or it's not otherwise available or possible. And now we get down to you've gone through your traditional approaches, and do they meet ECMO criteria, Eolia criteria? Now let's just, in the last couple of minutes, talk about rescue ECMO, because I drew a distinction of salvage ECMO when all else has failed, and rescue ECMO, where you're bypassing components of the algorithm, going straight to ECMO to quote unquote rescue the patient. So you could think of this in a couple ways. There's two different scenarios. Either something like proning, the optimal management that you would prefer to offer is just simply not available where you're providing care, or they're deteriorating too fast and it seems almost silly. Of course, you could always flip a patient on their stomach, but there are scenarios where perhaps you can get ECMO faster than you can get a team together to prone a patient, or you feel like they're just too unstable that they're not going to tolerate flipping them over onto their belly because of refractory shock or some other circumstance. And in either scenario, instead going straight to ECMO and bypassing prone positioning as an example of rescue. So if you think about it, if Eolia showed that ECMO in the setting of optimal conventional mechanical ventilation and management strategies, including prone positioning, still improved outcomes, then certainly if you couldn't provide optimal conventional management, then ECMO would provide a benefit over suboptimal management, right? So if Eolia is positive, then not being able to offer prone positioning and strict lung protective ventilation and paralysis, certainly not providing those things would increase the mortality, and providing ECMO would provide an even greater benefit than we see in Eolia. So in conclusion, based on Eolia and the subsequent Bayesian analysis and network analyses, early ECMO, the Eolia trial, is better than salvage, but rescue may be necessary and justifiable in circumstances where other proven strategies are not available first. And I'd like to thank you for your attention.
Dr. Adams, that was a wonderful talk and very nicely put forward the different types of ECMOs and their practical use, how to consider them. So I request the audience, our viewers, any questions you have?
Feel free to put in the chat. Take a look at that as well.
There's nothing so far. So maybe I can just put up a couple of questions, Dr. Abrams.
Sure.
When do you consider futility in ECMO?
Say again.
When would you consider futility?
Futility when they're already on ECMO?
Yeah. At what point would you? Yeah.
Yes, that's a very good question. It's obviously a complicated question. I think, assuming we're doing ECMO in this case for someone with severe ARDS, right? Because obviously there's other reasons for ECMO, there's other indications, including bridge transplantation, and which is its own, question of futility or when they can no longer, be considered for transplant. The question of when ECMO is no longer working for ARDS is definitely an unanswered one, because there's increasing publications in the literature of very, very, very long runs of patients on ECMO for ARDS seeing subsequent recovery, not just weeks later, but months later. And I mean, we even saw, kind of jumping the gun in COVID, where patients were being transplanted 3 weeks into ECMO, which was still very much in the acute phase, thinking they weren't going to recover and that they were going to have to go on to transplants. And that I think is very premature. Um, yeah, if it's just the lungs, you could probably hold out for quite a while. If they're accumulating other organ failures and they're just, the whole picture is showing, increasingly poor chance of recovery, that's sometimes an easier thing to understand. I think the lung has an incredible ability to heal. And we've seen this with some of our patients where we'll take a strategy of bridge to recovery, but try to keep open the potential for transplant at the same time. That maybe months later, they're just simply not showing any signs of recovery. We don't have any good measures of that. We don't know when the lung is simply too fibrotic and too scarred for that patient to recover. There may be opportunities to come off ECMO and just onto the ventilator. I would, hesitate to come onto very high ventilator settings if there was still an opportunity for resting them and recovering them. But I would warn that I think people call it too early. People say that they're irrecoverable too soon and should really push the envelope for how long, assuming it's not everything else, everything else isn't falling apart at the same time. But there's no good endpoint. I've just been called by a lot of centers for advice where they're 2 or 3 weeks in and like they're not getting better. I think we want to transplant. I think give it time. Keep that option open if you could keep all the other organs functioning, because maybe they'll need it. But I think people overestimate or underestimate the ability for patients to recover if you give them long enough. I see a question. Okay, thank you for translating into everyday practice.
There is a question
Yes.
by Dr. Giori. Thank you for your excellent talk. Then translating that into everyday clinical practice, what would be the optimal timing for initiating ECMO after the first prone session without improvement, after neurovascular blockade, and what do you think is the ideal window? So this is
no, that's a really good question, and I'm glad you brought that up because we encounter this many times. So we try to really truly strict to EOLI enrollment criteria, and that is if you are conducting, they are first prone positioning, right? I get them lung protective ventilation, dry them out if it's appropriate to dry them out, start prone positioning, which is so underutilized despite all the evidence in favor of it. So many centers simply don't do it, and I think it's just there's a lot of reasons and barriers, but I can't encourage that enough. ECMO has its risks, and you're cannulating patients, you're doing surgery, you have vascular risks, you have other complications. So definitely do those things first. I think as long as they can, this is tricky because as long as they continue to quote unquote respond to prone positioning, and oxygenation response doesn't necessarily equate to prone positioning response. But if they're continuing not to meet criteria, if you have them prone and they don't have 6 straight hours beyond of PDAF less than 80, and they do have an oxygenation improvement, they don't meet criteria for ECMO. You complete your prone session, 16 hours or more, flip them back supine, reevaluate. I would continue to do that so long as they don't meet criteria for ECMO. The tricky part becomes, as you may be alluding, what happens, what's that window? Because what if they've been proning for 7-8 days and now they meet criteria for ECMO, but now they're 8 days into their management? And that's it. Did we miss our window? And I think 7 days is thrown around a lot. It's a soft barrier. I don't think we have the strongest data to say beyond 7 days they're irrecoverable. But I wouldn't prematurely do ECMO if they don't meet criteria, because what if they had gotten better by day 7 or 8? Then you didn't give them that opportunity to put them on ECMO instead. It's an individualized decision. You have to make the best judgment, which we're pretty strict. We really do try to adhere to that. They don't meet criteria. They do meet criteria. But we have encountered those scenarios where, because we're being so strict about it, now they call back 10 days in. They say, well, you told us to keep proning, and now they don't meet they meet EOLI criteria, but they're too late. There's wiggle room there on how long it's been. And maybe they haven't been exposed to such high pressures for all 10 days, and you feel like it's not too far gone. But I'm pretty strict to the EOLIA entry criteria. And if it means that they are no longer a candidate, however far out, I think it was still worth the opportunity to see the benefit from Prony. But that may not be a universally held feeling. Does that make sense?
Yeah, great, Dr. Abrams. That's wonderful. So I just want to, you have so much experience. There is this, you know, literature which says that if you maintain the patient on the ventilator of ARDS and you're able to ventilate him well, a fraction of these patients over a period of a couple of months reverse the fibrosis they're going into and do come out. Is that actually true? Because you can't just as a query I want to ask, because all the patients cannot be put into ECMO. Sometimes their ECMO is not available everywhere. Lung transplant is not available everywhere. So what is your thought on this? Have you seen such patients, and what is the current opinion on this?
Sorry, the patients do their
Yeah,
describe the scenario.
the ARDS patients, if you ventilate them, they go into fibrosis for a prolonged period. But this fibrosis
Yeah.
is reversible. That is what literature mentions in a certain fraction of patients. Is that actually true? Have you seen such patients?
I have seen, okay, I mean, these are, I could give you an example here, an example that it doesn't define, we don't know who these patients are. But as an example, I was telling you about someone who was, prolonged ECMO, but we were keeping open the option for transplant or recovery. I mean, if I could show you, if I could pull up on the screen, I should probably include it in a slide next time. Such severe fibrosis, large bullae bronchiectasis, traction bronchiectasis, I feel like looks like something that often, it can be, transient and reversible. But such horrible fibrosis, we kept at the point where we received him, which was already a few weeks into ECMO. He had started in South America, ended up in Texas, then came to us for developing pulmonary hypertension and RV failure on top. And we took the ventilator off to try and minimize the positive pressure and just gave him opportunities to try and wake up and preserve his other organs. He had complete recovery over the subsequent month. And if you saw these images, you'd say there's no way these lungs can recover. So yes, I think there is definitely a population. I don't know who they are. I don't know that we have the biomarkers to demonstrate who these patients, maybe there's some proteomic profile that defines these patients. But I think it's not a foregone conclusion that you see some fibrosis from ARDS and all of them are irrecoverable. And that's why I think it's people probably prematurely, in some cases, get transplanted, and now you're giving them a life expectancy of, on average, 6 years, versus if they hadn't been transplanted, potential recovery, maybe some debility, but some ability to recover beyond that. So ECMO is a great tool, and it really what ECMO is doing is allowing you to decrease the ventilator and just applying less pressures and volumes and trying to minimize the injury we're providing, we're doing to the lungs. I don't think it's a cure-all. If we could provide that kind of lung protective ventilation without ECMO, I would be in favor of that too. Like, I think that's why these lung protective strategies are so important, because ECMO just magnifies that ability. But it's not, I don't think it's the cannulas itself. It's just the ability to take the gas exchange off the patient.
Yeah,
I don't know if we have time for maybe one more question.
One more question, last question, Dr. Abrams, if it's okay with you. This is by Dr. Ricardo, who's from I think he's your colleague in Toronto. So he says, Ricardo, in your experience, do patients with preserved normalized elastance or normal compliance who only meet oxygenation criteria and are otherwise receiving low intensity mechanical ventilation also benefit from ECMO?
Right. So good question, Ricardo. And I know you know a lot of this literature. So when you look at, but I didn't include the talk, but if you look at the EOLIA entry criteria, right, there's 2 oxygenation criteria, and there's one that's more about respiratory acidosis, compliance, dead space. You can kind of interpret that third criterion. Enrollment was not stratified by criteria, so it's not evenly distributed, control and intervention in each of the 3 strata. But the greatest absolute, just on the surface benefit was in that third criterion. So that's probably true that those with impaired elastance compliance are the ones to benefit the most from the ultra lung protective strategy. I think that's where the greatest benefit is. For what it's worth, since we can't really tease that out in the trial, there were many enrolled, obviously, for the PDAF less than 80, not so many for PDAF less than 50. So I don't think people are dying from refractory hypoxemia, but maybe there's still, even with normal compliance and elastance, there's an added benefit of going even lower, even if there are a lot of, compliance is not the major problem in their ARDS. But I think it's probably as we go to ECOR, extracorporeal CO2 removal, and trying to find more patients that can benefit from an extracorporeal strategy to reduce, volumes and pressures in villi. I think that's probably the subset. The patients with the highest driving pressure are the ones in the impaired elastance, as Ewan's demonstrated many times, Ewan Gallagher. Those are probably the patients that are going to benefit most, and not the ones with hypoxemia. So I agree with Ricardo that it's probably, we could refine this more. We're not going to see another Eolia trial, but I think as we try to expand the population that can benefit, it's going to be that subpopulation with more compliance and elastance issues. Yes.
That's wonderful, Dr. Abrams. Thank you for the answer. And I think that is all. We shall close the session now. Thank you very, very much, Dr. Abrams, and hopefully we can have you again on our educational programs when it's convenient to you. Thank you very much.
Thank you, guys. Have a great day.
Have a great day.